welcome on our channel, and today we are going to discuss about the new topic, that is acute rheumatic fever. And what is that? Let's discuss about it. It is usually occur between the age of 5 to 15 years in children and young adults. It is mainly present in Asia, Africa and South America, and it is caused by group A streptococci. Okay. Then clinical manifestation or clinical features of acute rheumatic fever. It is multi-system disorders that usually present with fever, anorexia, lethargy and joint pain, and the latent period 2 to 3 weeks after an episode of streptococcal pharyngitis. Diagnosis is made using the revised Jones criteria. If this criteria divided into two: major manifestation and minor manifestation. If two or more major manifestations are present, then it means the rheumatic fever are present or positive. Then if the one major and two or more minor manifestation is present, then it is also the rheumatic fever is positive, along with evidence of preceding streptococcal infection. Then it is the revised Jones criteria. What is that? What comes under major criteria and minor criteria? In major, carditis, polyarthritis, chorea, erythema marginatum and subcutaneous nodules, which we discussed in the next slides. And minor manifestations: fever, arthalgia. Arthalgia means joint pain and previous rheumatic fever, raised ESR, leukocytosis, first degree AV blocks. Then what is carditis? It involves when all the layer of the cardiac system involved, that time it is known as carditis. Okay, these are which layers are involved? Endocardium, myocardium and pericardium. Okay, incidence decline with increasing age. When age is increased, that time the incidence of this problem decline. The 90% of chances are there if the child is under the age of 3 years, and only 30% if adolescents. And there are some clinical manifestations are there, like breathlessness, heart failure or pericardial effusion, palpitations or chest pain, then tachycardia, cardiac enlargement, cardiac murmurs are there, then aortic regurgitation present, syncope also present, and ECG changes. In ECG, ST and T waves changes are there. After that, arthritis. Most common and early manifestation of rheumatic fever. In this condition, the patient suffering from acute pain and typically affect the knees, ankles, elbows and wrist. Okay, this pain might be responded by aspirin, and if not, the diagnosis is doubt. Then skin lesions. Erythema marginatum. What does it mean? It occurs in less than 5% of patients, and lesion starts as red macules and fade in the center but remain red at the edges. Occurs mainly on the trunk and proximal extremities. Proximal means near the central part, and but not on the face. This the erythema marginatum not occur on the face, but it is present on the trunk. Subcutaneous nodules occur in 5 to 7% of patients, and small 0.5 to 2 centimeter, firm and painless. Best felt over extensor surfaces of bone or tendons, typically appear more than 3 weeks after, help to confirm rather than make the diagnosis. Fine. This is the subcutaneous nodules, which you can see very clearly. Then it is also the subcutaneous nodules. Erythema marginatum. It is the discoloration of the skin or something present on the skin, which we can see on this image. Then next is Sydenham chorea. Sydenham chorea, which we can see on the picture. This is looks like dancing step, but it is the abnormal position, abnormal activities done by the person who are suffering from rheumatic fever. And it is late neurological manifestations, appear at least 3 months after the episodes of acute renal failure. All the other signs may have disappeared, occur in up to 1/3 of cases, and is more common in female. Emotional breakdown or changes may be the first feature. typically followed by purposeless involuntary choreoform movements of the hands, feet or face, and speech may be explosive or halted. Spontaneous recovery usually occurs within a few months with proper treatment. After that, investigations. In investigation, ESR and CRP, monitoring progress of the disease, then positive throat swab culture, endocardiography, mitral regurgitation are there, prolapse of the anterior mitral leaflet, and may also show aortic regurgitation and pericardial effusion. Then the next is management. Treatment strategy can be divided into management. First of all, if the acute attack, management of the current infection. In acute attack, management done on the current infection and to relieve the symptoms, and prevention of further infection and attacks. Then management of acute attack, single dose of benzyl penicillin 1.2 million unit IM and oral phenoxymethyl penicillin 250 mg 6 hourly for 10 days, and penicillin allergic. Erythromycin, if someone allergy with the penicillin, then they can give to the patient erythromycin or cephalosporin. Analgesia optimally achieved with high doses of salicylates, and treatment is then directed toward limited cardiac damage and relieving symptoms. Then bed rest and supportive therapy are also provided to the patient. It lessens joint pain and reduces cardiac workload. Duration should be guided by symptoms along with temperature, leukocyte count and ESR should be continued until these have settled. Return to normal physical activity, but strenuous exercise, heavy exercises should be avoided in those who have had carditis too. Then cardiac failure. Mild heart failure usually responds to rest and corticosteroids therapy. Severe carditis. In severe carditis, provided digoxin, but its use should be monitored closely. Then vasodilators and diuretics also may be used. If heart failure in these cases does not respond to medical treatment, valve replacement may be mandatory. Then management again. Protected syndactyl chorea has responded to haloperidol. It requires long-term antimicrobial prophylaxis even if no other manifestations of rheumatic fever evolve. Complete physical and mental rest is essential because the manifestations of chorea may be exaggerated by emotional trauma. Then management with aspirin. It relieves the symptoms of arthritis rapidly, and a response within 24 hours helps to confirm the diagnosis. Reasonable starting dose is 60 mg per kg body weight per day divided into 6 doses. Then in adults, 100 mg per kg per day may be needed up to the limits of tolerance, or maximum of 8 gram per day should be continued until the ESR has fallen and then gradually tailed off. Okay. Then corticosteroids, more rapid symptomatic relief than aspirin and are indicated in cases with carditis or severe arthritis. Prednisolone 1 to 2 mg per kg per day is divided doses should be continued until the ESR is normal, then tailed off. After that, prevention is better than cure. That's why it is also focused on prevention. In primary prevention, 10 days course of penicillin therapy. About 30% of patients with acute rheumatic fever do not recall or preceding episodes of pharyngitis if they can take penicillin therapy for 10 days. And in secondary treatment, secondary prevention is directed at preventing acute GABHS pharyngitis, inflammation of the pharynx in patients at substantial risk of recurrent acute rheumatic fever. Primary prevention involves eradication of streptococcus from the pharynx and administering a single IM benzyl penicillin. Then secondary prevention, patients are susceptible to further attacks if another streptococcal infection occurs. Long-term prophylaxis with penicillin should be given. Benzathine penicillin 1.2 million unit IM monthly, oral phenoxymethyl penicillin 250 mg 12 hourly, and sulfonamides prevent infection but are not effective in the eradication of group A streptococci. Long-term antibiotic prophylaxis prevents another attack of ARF but it does not protect against ineffective endocarditis. Then the next is secondary prevention. How much time we require to take to give the secondary prevention to the patient. For example, these medication, how much time patient can take. According to the category, if the rheumatic fever with carditis, then the duration of the treatment at least for 5 years or until the age of 21 years, whichever is longer. And rheumatic fever with carditis but without residual heart disease, no valvular disease at least for 10 years or well into adulthood, whichever is longer. Rheumatic fever with carditis and residual heart disease at least 10 years since last episode and at least until 40 years, until the age of 40 years, sometime lifelong. Then the complications of rheumatic fever, because of rheumatic fever might be mitral valve stenosis are there, then aortic stenosis, aortic regurgitation also.